Welcome everyone to the very special session at the Festival of Public Health. My name's Arpana Verma, and we're going to be doing a lot of thinking through different aspects of how we engage with communities. And what I'd like to do is just some housekeeping. Please could you have your self on mute and switch your camera off. We have our Twitter handle, which is at Festival of PH, and our hashtag is PHFest 2021. So those of you that do such things, we'd encourage you to use that. A shout out to our programme, and if Angela wouldn't mind just putting the link to the programme in the chat function, that has all of our different sessions and the links, as well as a daily digest. So if you have missed any sessions, you can get a review of what we've been doing over the last few days, and also everything that's recorded will be going on to our YouTube channel probably within the next few days. We are so delighted that we were able to have this session, and the importance of the NIHR Biomedical Research Centre is how we're going to start setting the scene and then move on to our fabulous collaboration with Vocal, and Bella's then going to take over. So this bit is when I'm going to embarrass our speakers. I've known Ian longer than he's probably known me, and always looked up to him as just a fabulous role model for inclusive research. And it was when he moved on to our corridor, I was
Arpana, sorry, I've accidentally muted you. Can you?
We'll delete this bit.
We got to the bit where you moved, I moved into your corridor.
And I was
sorry.
No problem, Angela. I won't say what I was gonna, but it was those corridor conversations that are just so important in how we do research. And I think it's been one of the key things that I've missed out on, is seeing Ian's smiley face down our corridor. But it started a whole series of events, and yeah, you remain my hero, Ian, and we're just so pleased to have you speaking at the festival this year. And so I'd like to give you the floor. Thanks, Ian.
Well, look, Arpana, that's a really, really nice introduction, and thank you very much. You're absolutely right. I think a lot of stuff we do in research is about bumping into people, having quick conversations in corridors, and then making connections. So, so thanks for bringing someone who does a lot of translational research into a Festival of Public Health. And I'm just going to set the scene a little bit, because I think the main meat of today is you're going to be hearing from some public contributors and from Bella, who's doing a lot of work in this area and leading the charge in this for the BRC in many ways. So just to put you in context, you've seen this before a number of times. So the Greater Manchester population is about 2.8 million, over 200 languages spoken, very large ethnic minority population, which is growing, but very, very high levels of inequalities and deprivation, high unemployment rates, children not ready for school, life expectancy is below the England average. As part of the civic response to this through devolution and through the Greater Manchester Combined Authority, there's an aim for people to start well, live well, and age well. And Manchester, you will know, is a WHO-friendly city, and we're also a Marmot City region, which goes back to one of the talks we had earlier this week. So a biomedical research centre is focused mainly on translational research. So that is taking basic science discoveries from the university, linking that with translational excellence in the trust, getting citizens involved very early in the process to drive new innovations through, to understand proof of concept that things are worthwhile taking forward into wider deployment. And so therefore the BRC and the CRF sit, if you like, we think at the beating heart of the Greater Manchester system. We link into the Academic Health Science Centre, and through Health Innovation Manchester, hopefully take innovations out at pace and scale with equity out into the Greater Manchester community. And that's our sort of focus and drive. And so we co-produced a mission statement a few years do is we're driving health improvements and lasting change for all through creative, inclusive, and proactive research that identifies and bridges gaps between new discoveries and individualized care. So the BRC itself is trying to, if you like, develop innovations with a Made in Manchester badge to them, sort of ideas that are generated through Manchester to drive out to the wider community. A number of the themes we have include inflammatory diseases, so musculoskeletal disease, skin disorders, chest medicine. We've got a big emphasis on hearing and deafness, and then a number of cancer themes, including prevention and early detection, radiotherapy, and precision medicine. We've cross-cutting themes on developing biomarkers, using informatics and data sciences to strengthen our insights into disease, and then rapid translation to try and take things through at pace. Supporting all of this is a very strong PPI&E program, capacity building and training, and industry links as well. So P4 medicine, for those of you who aren't familiar with the term, stands for predictive, preventative, personalized, and participatory care. So can we predict better who are going to develop disease or develop complications of the first disease they've got? Can we prevent that? How do we think about prevention of disease and complications? How do we personalize care to individuals? And how do we get patients to participate further within their healthcare and health status? And of course, pivotal to all of that is patient and public involvement and engagement. It connects people with research for mutual benefit. So researchers learn from patients and the public, and hopefully we help to increase the awareness of the work that we're doing. And a big focus of Vocal is involving diverse communities with research, and then innovating with creative arts, contributing to the PPI&E, and then building further capacity within our research teams, etc. So we were working very hard on a program delivering across those themes. And then, of course, along comes COVID. And I thought it was quite interesting. I suppose a mask is one of the great symbols of the last 18 months, and we might touch on those in a few seconds. And of course, the public health messages come out. And you may remember this infamous poster, which tells us all to stay at home and save lives, particularly the women, to stay at home and do the ironing, to look after the kids, keep the house clean, and comfort your dear husband or partner when he comes home at evening. So I think this advert was probably pulled rather quickly, but suggesting that EDI doesn't quite permeate everything. One of the things that we did with Manchester was we had a disparate group of people doing a lot of research in response to the COVID pandemic. So we set up this overarching group called the Greater Manchester Research Rapid Response Group, or the R3G group. And this was set up sort of very early towards the end of sort of mid-April. And really it was to try and coordinate the response to the research response across the whole of Greater Manchester, with a clear focus on prioritizing research that would try to minimize lives lost, to minimize the impact of the crisis on our health and care systems and on our citizens. So really the priority was to pull together the NIHR infrastructure, the trusts and the universities, and to link Manchester's work to national priorities because we were in a national crisis. And so that meant that many of the key subject areas that we were focusing on included new treatments and clinical trials, because there was no treatment at all available for COVID when it first hit in March. In order then to suggest new treatments, one has to understand the mechanism behind the disease, what's driving the disease and its complications and its mortality. We then had a major emphasis on data science to understand the modelling and mapping of the disease, public health and social care impacts, and then looking at how COVID was impacting people with chronic health conditions. There was a further series of areas around novel diagnostics. You'll remember back to when we had virtually no capacity for diagnosing the condition, and how do we improve that? How do we deploy preventative and vaccination programs? And then thinking wider about the organizational changes within the university and the systems, and also then global health aspects as well. So essentially, we ended up, sorry, that slide's unstable, but we ended up looking at and supervising over 189 projects across a very wide spectrum of conditions. And GM not only contributed to the national programme, but led many of the many of the national programs. So things like a phase 2 platform trial to try and identify new treatments for COVID. Our immunology team led a huge effort on looking at the immune response to the virus, again, to try and suggest new treatments and interventions. Rick Boddy and the team at MFT helped set up the Condor program, which was essentially looking at new diagnostics and trying to rapidly evaluate in real time new diagnostics for COVID. Our hearing health team had a huge impact. I showed you that mask earlier. If you're in hospital and your hearing is impaired and you've got an oxygen mask on that's hissing away, and you can't have your hearing aids in, and your doctor comes along with a mask, a face visor, frightening situation. And our hearing team really stepped up to try and sort of describe and understand this better and to publicize this as a major issue. And it keeps them well and it keeps them functioning well. So we had a global effort to try and understand which of our rheumatological drugs or immunosuppressive drugs may be deleterious for people with COVID. And similarly with cancer, trying to understand cancer outcomes during COVID. There's a lot of that in the news, and a number of our teams at the Christie in particular were leading the national effort in understanding that. So Manchester as a conurbation and as a system contributed extremely well to the national effort. Over 2,000 patients into the recovery trial, more than 3,000 people now in vaccination trials, etc. So examples of big initiatives. One was the Greater Manchester Mass Testing Expert Group. So the Greater Manchester Healthcare Authority wanted some expert input to what was happening with testing, because the testing program was rapidly evolving at pace, and it was trying to disentangle what was the best evidence, what was the best approach to testing. And so we pulled together a team of academics, clinicians, public health practitioners, general practitioners, and many subject area experts into a mass testing expert group to review the best evidence for testing regimes, guidelines and recommendations that could be deployed across the whole of the Greater Manchester footprint, and then horizon scanning for new testing that was coming through. And that's been a very successful group that continues to meet on a regular basis. We also were able, with some philanthropic donations and also with repurposing funding from the BRC, to support about 12 different new. So what have we learned from all of this? I think we've learned a lot. The first thing I think researchers work together, whether they're basic scientists, translational researchers, public health people, whatever, integrating that all together delivers effectively for the national effort. we had per head of population, we have recruited maybe more patients into COVID studies than any other part of the country. So that strong regional integration delivers for the national effort. It also maximizes local citizen benefit. We know that participation in research improves outcomes. If you were in the recovery trial and recruited to the recovery trial and you get a successful treatment like dexamethasone, we know that there were patients benefiting from the very beginning in Greater Manchester. Under the COBE notice, we were able to integrate the care record for the whole of GM together, and that is now being used to understand the pandemic better, and it's got secondary. If that ability to use it for secondary research purposes goes beyond the COVID era, then we'll be able to do that for other disease areas as well. You saw this slide on Tuesday from the IHE team and from the Building Back Fairer in Greater Manchester report. And what this really shows is the startling excess mortality from COVID in Greater Manchester, about 25% increased across the England average. And some of our more deprived communities had much, much higher mortality from COVID. And so that brings us back to health inequalities. And I think one of the other things we learned and really underscored as part of the pandemic was how health inequalities were exaggerated and brought into very sharp relief by the pandemic. And that underscores the need to focus our research further to address health inequalities in our communities. I think we need closer alignment of the discovery and translational science with applied research and implementation so we can accelerate things through for our citizens, particularly those in more deprived communities. And that is kind of the lesson, but actually the groundwork has been laid by Vocal and the team that you'll hear from in a few minutes around health inequalities, because we've got a health inequality steering group linked between our Biomedical Research Centre and research facility for about 3 years now, as I say, led by the Vocal team, addressing barriers and opportunities to inclusive research, developing briefing notes for researchers to consider health inequalities, doing actual reviews of participation and showing that actually we're becoming more representative in our recruitment, etc., and engagement processes, and doing place-based engagement activities in many parts of the conurbation, not just in the centre of Manchester, but in places like Oldham, Wythenshawe, and Wigan. And that steering group is continuing to learn and do new things, identifying gaps in communication that still exist, trying to integrate things better across the NIHR infrastructure, linking with GM community organisations, further developing stakeholder relationships in areas of low participation, and improving the PPI and the offer by linking more with community centres and community organisations and primary care facilities, etc. So you're going to hear from some of these in the next few minutes, but basically we've got speakers and representation now from the Black and Asian Minority Ethnic Research Advisory Group, and I'm delighted to welcome them and thank them for their input today. You're going to hear from Professor Bella Starling, who's going to tell us about an online inclusive research module, and also from the NIHR Centre for Engagement and Dissemination, Dr. Carr. So thank you very much. I'm happy to take any questions, but thank you for your attention. I'll stop sharing.
Thank you, Ian. So I'd like to open this up for questions. I'm just trying to get the chat back up. Professor Bannock, did you want to talk about your post in the chat? I don't think.
Evidently not.
No. So this is about CARP theory. which it's not something I know very much about. Ian, is this something you know? I will Google it straight away though.
Let me look at the question.
Whilst we're getting people to think of questions, we've got obviously this huge potential with the BRC for public health research, and I think your vision for how it links up with these early phase trials is just so important, and the prevention agenda, and it's been really helpful being part of those discussions with the other theme leads as well. In terms of where do you see the latest set of thinking behind where NIHR would like us to go in terms of the BRC?
So obviously we're in the middle of the application sort of rounds at the minute. So but I think that the way I see this is that what we learned from COVID was by pulling in public health expertise, by pulling in detailed knowledge of our opportunity to think about how translational research can work for maximum benefit. So one example of that would be, as you know, they're building a brand new hospital in North Manchester, which is one of the most deprived areas of the city. We probably need to make sure that there is access for that community locally on their doorstep to take part in the kind of research that we do. So that's one thing. The second thing is, you'll know from a number of the initiatives around the hearing and hearing health theme, some of the lung cancer prevention work, that actually taking research to a community, using whether it's a person in a van, whether it's using some mobile devices, etc., that one can actually include more people from communities in the kind of research you want to do, and actually understand what the blockages are and what the obstructions are, and also not to widen inequalities. And I think you've made this point a number of times, that with digital access, that can actually have a negative effect of widening inequalities. So making sure that we're asking those questions at the very beginning, and not after we've done some proof of concept work to say, this is a really good idea, and then you realize you can't actually take it out further.
Thanks, Ian. Any other questions from our delegates? Jenny, are you able to unmute?
I can. Hi, Ivana. Hi, Ian.
Hi, Jenny.
So I guess I was just wondering about the feel that you had for how likely that GMCR data is going to be available for research outside of COVID research. I sort of mentioned in the chat, I don't think routinely collected data widens participation completely, but it certainly is a step further. You know, people are more likely to come to a hospital appointment than they are to take part in research, and it's easier to access that. But I have concerns about the governance, I guess.
I think one of the things, yeah, so that's a very good comment. I think I don't know the actual answer yet, Jenny, but I think that given the benefits of having had some of the secondary uses that it's been deployed for, I think as long as, if there are systems of local trust and local governance in place, I think that we'll find that that will be allowed to continue beyond the COPE notice. I think my understanding is the COPE notice is meant to be end in some time like September this year. Whether it gets extended or not, we don't know, but I would be hopeful that if we can show good governance in how we're dealing with this currently, that we should be able to continue it long term. But I think it's not a given. We just heard some of the controversy recently. Other efforts in this, we have to make sure we distinguish from that and say there's local governance in place. I think using things like citizens juries and some of the citizen involvement in Manchester, I think is the way to do this. You need to build trust from the ground up.
Brilliant. I'll remain optimistic then.
I believe we are taking proposals, Jenny, for non-COVID through the governance group. Also, I think your point is really valid, and it'd be good to discuss further with you about some of the projects that we had in mind to really focus on that, because I think the impact of MSK outcomes can be hugely influenced by some of the things that we do in public health. And I know I'm preaching to the converted, Jenny.
You are, yeah. That'd be great to talk more, Ivana. Thanks. And good to know about the call. I'll look into it. Thanks.
Any other questions? Ian, can I just ask then strategically about the RRRG? I always sound like a pirate. R3G. Is that something that we're going to continue? Because I know we've got sort of the long-term effects of COVID, and not just long COVID, but the things that it feels like both the rapid response, the public health research calls for the urgent projects, they still were very medically focused. And even now, a lot of the like long COVID bids, it's still all about the medical models, whereas we know we're going to have that tsunami effect of all the issues with the economic and the social issues. Is that something that we can continue to think about through our group?
Yeah, so I think that what we wanted to do, we had the rapid response group. Then as things have sort of flicked back with restart and all of that, we felt that it's probably what we want to do is keep the essence and the good aspects of the research rapid response group and take them into sort of the NHR, sort of the integration of all the NHR infrastructure within Manchester. And that probably maps what the NHR are planning, which is that COVID research becomes a theme within their NHR portfolio. In the same way as you've got an MSK and you've got an immunology theme, they will have a COVID theme. So I think within Manchester, we should be making sure that when we put together our NHR sort of integrated strategy, that we make sure that COVID is a theme within that, because I think you're right, the downstream consequences of this are going to be very long and quite varied across translational, applied, public health research, social science research, etc. Thanks.
Brilliant. So just would like to thank you, because I know you have to rush off and how busy you are. So thank you again, Ian. It's just been fabulous having this opportunity to hear you speak. Thank you. And now it's Bella's turn to be thanked. So Bella and I, we've only really started to work together over the last few years as we have been part of the Health Inequality Steering Group that Ian mentioned. And it's just been eye-opening to see all the fabulous work that Bella and her team at Vocal do. And then she kindly introduced us to Bragg, and we were able to see the awesomeness of some of our speakers that are here today. And so I'm just so pleased that in recognition of all of Bella's awesomeness, she was awarded a masked chair, and now we can start calling her Professor Starling. And so I will carry on as Ian has and introduce Professor Starling to take the stage. And thank you so much for agreeing to speak to us today, Bella.
Thanks very much, Arpana. I feel suitably embarrassed. Well, thank you. A little bit proud, but also a little bit embarrassed. So thank you very much for that. And I'd really like to also welcome Circle and Ehinor, who are going to join me in the presentation and the discussion that we're going to have now. So I'm just going to do a couple of introductions and a couple of slides, and then hand over to Circle and to Ehinor, and then I'll come back and I will launch our online learning on inclusive research that will be available from today. So if I share my screen, great. I hope everyone can see that. Give me a sign if you can't see that.
It's not on the thingy view.
No.
Can you see that?
Brill. Thanks, Bella.
Yeah.
Great. So so my name's Bella. I'm director of Vocal, which, as it says on this slide, is all about bringing people and research together. If you're working in research, you might understand that some of the work that we do is called patient and public involvement, or patient and public engagement. But really, we just like to talk about bringing people and research together across different communities and different research areas. And what I'm going to cover today with my colleagues, Circle and Ehinor and others, is just about working together inclusively in research. And you don't need me to tell you that the toll of COVID has not been equal. Ian has already alluded to this. This is a cartoon from South Africa, but could easily represent the situation in England and the UK. And you know, it's been a tough time and continues to be a tough time, and no more so than for some of the community partners that we work with as part of Vocal and as part of the Manchester Biomedical Research Centre. So I just wanted to flash up this slide that introduces our colleagues Ehinor and Wai-yin and Circle from the Wai-yin Chinese Society. Just by introducing to say that, you know, voluntary community and social enterprise organisations have played a vital role in the COVID response, filling service provision gaps, but this has also really underlined some of the financially precarious situations that they already work in. And I'm going to introduce Ehinor and Circle, who are part of Vocal's Black, Asian and Minority Ethnic Research Advisory Group, one of a number of our Vocal Research Advisory Group. And they are just amazing people who advise us on all the research that gets carried out, or some of the research that gets carried out through the Biomedical Research Centre and beyond. And I just want to hand over really to Ehinor and to Circle just to introduce themselves, say a few words about their experience and how we work together inclusively in research. So over to you, Circle.
Hi, everyone. I share first. My name is Circle Stewart. I'm the Chief Executive of Wai-yin Society. We are a charity serving the Chinese community in Greater Manchester more than 31 years, and also serve other diverse community. Now, during the COVID, we are very busy. We never stop at the front door because the COVID, as you outlined, is inequality. Yes, especially for health and social care. Now, I would like to share some example how we work together with to provide mental health support during the COVID-19 with other charity. Because beginning of the COVID crisis, we have a lot of mental health issue, crisis going up. And then we join up together, not only Wai-yin Chinese, the other organization from Jewish, from South Asian, from Middle East, we come together, talk to the commissioner about the support. So the first point I asked is about the mental health, cultural appropriate Chinese people, Chinese speaking counselor. The first door I've been pushed out is according to the OMS data, you're not a priority, Chinese community. I was in the shock, okay? I was a bit angry in the first meeting. I left the meeting, I coming back and then asked why and push my proposal inside. Okay, at the end, we got the resources. But what I'm saying is now earlier about the Ian or the people questioning about the data, about the mental health issue support. But what I'm talking about, sometimes the statistic, I call it cold data, it's all figure, or the data, or the number, does not reflect the reality of the life of Chinese community. We know better, and then we're working to them, and then we have better understanding their feeling, their need within the community, with a lot human connection, contact with those very vulnerable users. A good example, during the COVID, why we say the mental health support case gone up very fast. And one of the Chinese young people users, anxiety, worrying, and then they refer her to the statutory for counseling. It's no Chinese speaking person, counselor, service provided. They provide her interpreter, and then she finds it very unacceptable. And then she can't express her feeling, her anxiety. So what we are talking about, of course, I get the additional resources. What I say is to provide culturally sensitivity, culturally competent service to those users. At the end, we got quite a lot of referral to support the most vulnerable people in the community. And also, at the end, I do, the commissioner to apologize to us. He said they single out for Chinese community from the beginning. Now, this is only example how important the inclusive research to engage community, and those community can engage those vulnerable users. I tell you, our community user a lot is English, their second language. They won't come in to take your survey, tell you blah, 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 all this, because this language ability, and also depends on our frontline worker as to advocate their need and voice their needs and influence the change. I always say influence change because we time I challenge is that our sub user also test player. We have community people die in the COVID, a lot of bereavement, a lot of crisis happening. Why have always tried to fight this provision? But honestly, this provision for Chinese culturally sensitivity speaking, we have Chinese speaking council from Cantonese and Mandarin and psychotherapies. We need this service for a very long time, but just because COVID, suddenly everything's coming out. Yeah. So a dual article, and then well, I've been happy for Bella to share the article to your academic research. So what I always say, the academic research is important to engage community with your research as part of the process. Yeah. Thank you.
Oh, thank you so much, Circle. I think you've provided just an amazing and really moving example of the absolute need for cultural sensitivity and the real importance and the real value of lived experience to service provision and to research. Thank you so much, and you know, amazing work that I hope that you will have a long time to flourish. Over to you, Ehinor. Did you want to say a few words about your experience and working inclusively? Oops, I think Ehinor, we might have just lost your connection a little bit. Can you hear us?
Support women and girls who have experienced significant adversity. And what we do is help them build their confidence and support networks so they can thrive. I'm just going to talk about the experience, maybe one or two experience I had as a community leader when the pandemic started. When the lockdown started, one of the biggest issues we had in our community, because I represent African left out. Many of the women that we work with, they even understand what the government guideline was about. Some had, information that wasn't true. For example, when the lockdown started, what we did was to make the staff and the volunteers to, call the service users to find out how they were coping, if they were okay, and if they had food at home. And I remember one of the women we called actually was crying on the phone because she was hungry with the children. And I asked her, why are you hungry? Do you not have food at home? Do you not have money, to buy food? She said, no, I'm hungry because the government has told us to stay at home and not to go out. So even when she ran out of food, she couldn't go out because she didn't understand that there were exceptions to not going out. And that was how we started, using the Pidgin English language, which is a common language in the African community. We've been translating in Pidgin English since 2017, when we first did the community sandpit that led to BRAG. And I think then people really didn't take us serious as to why African communities do not, get involved in so many things, especially research. So we started translating in Pidgin English, the government guidelines, what they have to do and what they shouldn't do. Another important thing that happened, which I hope that, even as the lockdown has eased out and people and lives were getting back to normal, what I want the community or the government to address was the cultural appropriate food. When they were making announcements of the amount of food that was going out in Manchester, for example, for the meetings I was attending, my question was, how many percent of African families are accessing this support? Many of them couldn't give me answers. Later, some counselor called and said, you know what? Very few Africans are actually, asking for the food. And when we take the food to them from the council, they tell us to take it back. I said, do you know why? They said, no. I said, did you even bother to find out why a family who is hungry, you bring the food to them and they're not able to eat it? I said, because those thin food, we don't eat it. It's not culturally appropriate for them. The children were hungry. I personally, spoke to the counselor to say, this is what we're facing. We need food that children can eat, African children. And they asked, oh, okay, we will get back to you. And I remember somebody from the council later called me that evening and said, you know what, the council doesn't provide African food or cultural appropriate food because it's not an essential food. What we provide is what you must take. After all, it's about surviving. Why don't you tell your community to just boil rice and beans and eat? I was really shocked. And I asked her, I said, have you eaten African food before? She said, no. I said, have you eaten rice and beans, African beans and rice before? She said, no. I said, so why did you come up with that idea? I felt very discouraged with the council. And I told her, I said, this is so degrading. So degrading because it's not just about surviving, it's about equality. And right now, that equality, we couldn't see it. And up till I speak right now, the council never came back to us. Myself and my husband, we had to first initially use our personal money to shop for African food for our people in Manchester. Then we got other people involved who were now making donations for us to purchase African food. I don't know, even till now, we still struggle with funding to provide cultural food. Cultural awareness is still, at the back. Even when we are under the BAME community, in most cases, you have interpreters for the Asian community. We're under, when you talk about Caribbean and African community, the African community is still far behind. So we're just left out in the community. And I hope that as we progress, things will start to change, rules, those policymakers start to include us in whatever it is that they do. And as regards to research as well, most times I hear from researchers saying, oh, African community, we find it difficult for them to, be part of research. How can a woman, for example, who doesn't even understand English, be part of research? I remember when Bragg had a meeting, was it in University of Manchester years ago? And one of the questions I asked the researcher was, when you want to contact African community, do you use Pidgin English? They didn't even know what it was. And yes, BBC has BBC Pidgin English because they know that that is the language that African community can relate to, whether you're educated or not. They couldn't even understand, but so I believe that we are not included in whatever it is that is going on in the system. For us to be inclusive, we need to find out that cultural awareness. What do we need to do to get to people? How do we do it? And that's why I'm so passionate about Bragg, the vocal, because they're actually bringing people and research together in a more appropriate way, where you can reach out to the community. For example, there was a research that went on years ago about the breast cancer. The researchers were having challenge in getting African women of a particular age. I remember there was it Bella or Tracy who asked, are you sure, can you get us about 3 to 5 women? I said, I can even get to 20. Why? Because I know the language I will use. I know how to reach out to them. A typical African woman will not be in the news. They're not on Twitter. They don't have business with Twitter. They will be on Facebook and they will look and listen to people that they know. So we need to start thinking of those things. If we want to get involved with the community, who are we speaking to in the community? Which leader can actually help us reach out to the community we want to reach out to? So those are the things that I believe we can, actually go home with today. Like I say all the time, African community, the BAME community, we are not hard to reach. We are not hard to reach. We are very visible and we are always here. But you need to know who you're talking to. So I'll leave that for now. Thank you so much. Yeah.
Oh, Ehino, wonderful words, inspirational words. I can't speak for the council, but from my perspective, it's an absolute privilege to work with you. So thank you for you and for all that you do. I'm not sure I can follow that really, but I'm going to try because Bragg, Circle, Ehino and other wonderful colleagues have been really instrumental in working with us in Vocal to support researchers to be more inclusive. I am going to share my screen again. And hopefully you'll be able to see it. Do say to me if you can't see it. There we go. Because Ehino has outlined, kind of some of the challenges around being inclusive in life and in research. We start from the kind of ethical principle that those most affected or who stand to benefit the most from clinical research must be included as an integral part of research. But there's very many kind of barriers and obstacles in our way. I've listed some of them on this slide. I'm not going to go into a huge amount of detail other than to say that communications have not been tailored to communities. There's no requirement to capture, kind of ethnicity or other data, other demographic data about who takes part in research. And although patient and public involvement was missing in early COVID research, that is changing now. And, we're at a real tipping point, I feel, that we can keep things the way they've always been, as in this cartoon, or we can do something about it. And Nusrat, who I'm afraid couldn't be with us today, but has shared this thought and this quote with us, is that COVID has highlighted to all communities, including research communities, how pressing and important it is to address inequalities and to work inclusively. What COVID has also starkly shown is just how difficult it is to be inclusive, precisely because of all the inequalities that are entrenched. This is why an inclusive research approach is so important. Wise words from Nusrat, and Ian has already said a few words about, well, what are we doing about this in Greater Manchester? What are we doing about this as Vocal, as the Manchester Biomedical Research Centre, as the University of Manchester? And you'll have seen this on his slide already. I'm just going to say that today we're launching some inclusive research training. So this is training that has been co-created with BRAG, so Circle, Ehinor, and lots of other people. And this grew from an event that we held back in November 2019 and is now ready to be launched onto the world. And so I'm just going to show you where you can find this course. It's aimed at all researchers, but we have also aimed it at public contributors, so people from patient communities and community organizations, and just people who might want to become involved in research. And if I may, I hope this works, I can launch us into the training, and I hope you can see that. And you will find all kinds of helpful, well, we hope they're helpful, things in there. You can find out our definition of inclusive research. So we have an introduction, we talk about health inequalities here, and there's lots of also resources that you can download from the training.
Ella,
Yes.
it doesn't seem to be projecting. Do you mind trying again?
Let me see if I can stop sharing and then just see if I can find it. So if I share my screen now, can you see that?
I think we're about to. Yep. Thank
Great.
you.
So we have lots of definitions, we have lots of case studies, there's briefing notes for around health inequalities in research, information about barriers to inclusive research, and really importantly, pledges and actions that as researchers and public contributors to research that you can take to become more inclusive in research. So I'm assuming my slides will be circulated after this, and we'll put the link in the chat as well, and hopefully on the International Festival of Public Health website for everyone to access as they see fit. I'm going to leave it there with a final thank you to all members of BRAG, all members of the Vocal team who've helped to make this happen, but also all members of our partners team, and especially Catherine Wasiuk, who is, I'm going to embarrass by being one of the wonderful people who actually made this happen. So thank you very much. And I will hand over back to you, our partner, to introduce Mirat.
Thanks so much, Bella. Oh gosh, I've done that. Thanks so much, Bella. It's just so inspirational to hear you, Circle, and Ehinor talk. It blows me away, and speaking that truth to power, and couldn't agree with you more about the language that we use, and how as researchers we've really got to improve our game, and learning from you all has just been so fantastic. So without further ado, I am hoping that the Yes, Mirat, I can see you. Hi. Welcome to the festival.
Thanks, Evelyn.
And thank you so much for agreeing to speak to us today. Can I hand over the reins to you? And do you have slides today?
I do, but Bella, it says the host participant has disabled.
Yeah, we need to add you on, Mirat, and Angela will do that. Thank you so much. We'll just quickly do that now.
Thank you.
Hopefully that's worked.
Yeah, that's great. Thank you.
Thank you so much. Over to you.
So I think, thanks Bella for putting me after Circle, and sorry, I'm just trying to find, I can't multitask. Those presentations from the community setting, I think, really provided a fabulous example of what we need to do and why we need to do it. Circle and Ehenol's work really highlights that in a way that I don't think I can. So what I will do, and what Bella asked me to do, was just highlight how this fits into the National Institute of Health Research's work and priorities, and why the e-learning platform and the inclusive research agenda is so important for the future. And you've heard it all before, but basically, I come from the Centre for Engagement and Dissemination. This centre, very briefly, just brought together two centres, the NIHR Dissemination Centre and NIHR Involve. Those two centres had particularly different remits. The Dissemination Centre was to strengthen the spread and dissemination of the research that we produce, because it was acknowledged that that was particularly weak. And the NIHR Involve was a centre which really focused on how we create collaborations between researchers, healthcare professionals, patients, carers, public. So those two centres came together because there was really a need to strengthen how they work together as well. And so just very briefly, this is Jeremy Taylor. He's our director, and he is the Director of Public Voice in the NIHR as well. And on the dissemination side, we do a few different things, and this is very much with that inclusion agenda in mind. So for example, we have things called alerts, and this is all available on NIHR Evidence, which is website available, but these alerts are plain English summaries of research which might have been carried out in NIHR funded projects or programs. And then we also have collections where we bring together research on various themes. And then we also have themed reviews. And I'll speak about themed reviews next, because the reason I brought this in as a slide, but also the reason I focus on themed reviews, was it really highlighted over the last 12 months the importance of inclusive research and what we can achieve through that. So one of our themed reviews was on long COVID. This was incredibly early on in the whole pandemic. It was at a time when we knew that there was work needed to be done to bring together patients and the public, look at their experiences, and also look at the published evidence, and try and look at how we can bring those two fields together as they both evolved and as the pandemic evolved. So we carried out what we call a themed review. So these are rapid and dynamic reviews. And as I said, they brought together those two elements, published research and people's experience. And it was really important to have those people's experience and those people being part of this whole themed review. And that's because the person who's leading this was she was a nurse from a rehab background. So her view of going into this was like, let's explore rehab, let's explore what people need and how we can improve rehab for people with COVID. And it was only when we started to talk to people with the condition that we started to highlight, that they started to highlight what we now know as long COVID. It wasn't acknowledged at the time, it wasn't known at the time. And it sent this themed review in a whole different direction. So we started to focus on long COVID. Those people who lived with a condition were very much part of the process, very much part of us understanding the priorities. And so the question really changed to, actually, what can we do about this? What are the impacts of this ongoing effects, and what can we do about this? And for us, as an organisation, we're unsure we're going to get another themed review which is quite as successful as that long COVID one. It happened at a time when there just wasn't any information or data, when we didn't really understand what this was or even know that it was happening. So having those patients involved and having that whole different direction led to this being an incredibly popular review for us. It was picked up internationally and nationally by lots of media. Some of our colleagues were on the media left, right and centre. There was various articles, and it's still being cited in a huge number of articles. And also at a practical level, it led to us as a funder developing a whole call for long COVID and ensuring we include people to shape how that worked, but also developing guidelines and working and also evolving NHS England's work on emerging service models. And I've realised I've got an acronym in there, so apologies for that, or a few acronyms in there. So that was one example of how we did this as a centre and how we really try and model this inclusive approach, just because it really does have valid impact. And therefore that training package and the support is so fundamental, because actually we know the biggest issue isn't just what we need to do, but how do we do that? And so for the NIHR, one of the recent policy documents that we've had come out is called the Best Research for Best Health, the next chapter. This came out in June this year. And in that, Chris Whitty speaks about how one of the aspects of health research, one of the fundamental aspects, is really about ensuring we improve people's outcomes equally, because we acknowledge that that's not happening. There's enough data, and obviously in this session we've already highlighted all the data about the widening inequalities, and it very much is seen by the NIHR as part of our business and part of the research that we fund's business to start to tackle those inequalities. One of the core work streams that really aims to facilitate this is partnering with patients, and crucially, and sorry, all the rest of the people as well, but crucially the idea of this isn't just an end in itself, but it's because it's seen as a mechanism to improve the relevance, quality and impact of our research. And again, with that long COVID review, we definitely saw that. So again, really reiterating that this is such an important part of our agenda, and it is in our operating principles as well. Inclusion is one of our key operating principles. And these operating principles are all connected. So it's seen that actually we can't have, collaboration will be limited unless we focus on inclusion as well. And similarly with impact and excellence, these are all limited. These can all be limited unless we bring them together and really ensure that actually these operating principles work with each other. And we have some strategic areas of focus in that review as well. And there's specific ones, these four in the box, that I think are really, that we can't do without inclusion, and also really emphasize inclusion as the way forward. So from us as a funder, this is part of our agenda. It's part of our priorities. And we as a community, as a wider community, really need to ensure that not only are we ensuring inclusive research, but also we're feeding that back, we're disseminating how we did that and what are the results, and also how we, if that didn't work, what are the learnings from when we try things and it really didn't work, equally as when things work wonderfully. And just very briefly to finish off, so one of the things that we know is that the current evidence and the evidence over time hasn't necessarily changed and advanced in terms of this whole agenda. We're not really improving things as significantly as we could or as we should. And because of that, then we have decided to focus on these 5 areas of improvement in terms of engagement and involvement. And I would hesitate to put, so EDI is one on its own. Equality, diversity and inclusion is part of an improvement area on its own. However, I also think it's very much linked to the other 4 areas, such as value and impact and learning, digital engagement, standards, processes, and incentives. They all kind of link together. So that's it from me. I'll happily answer any questions, or you can contact me on these details if you have anything afterwards as well. I will just stop sharing.
Thank you so much, and that was a great overview of the fantastic work that you're doing, Mirat. I have a sort of a question stroke comment. I think what we found with a lot of the calls for NIHR, including the long COVID one, is that we're still focusing on that whole medical model, and as public health researchers, I think the impact of long COVID isn't about service delivery and redesign, and isn't just about the service delivery and service design. It's about the whole wider determinants of health, and the way that we look at the person within the setting. And I just wondered if NIHR are planning any sort of public health type calls to look at the impact of COVID as a societal issue, and the way that we're going to have to see that sort of One Health concept in terms of being able to tackle the implications of the pandemic in a much more interdisciplinary way.
Yeah, thanks, Sarah. And yeah, I definitely agree. And I think I'm not going to try and defend that we are very much in that medical space still. And I think the ongoing work with communities and the ongoing work by trying to bring health inequalities together with what we do will hope.
Oh, I think Mirat's saying yes.
I think Mirat is saying yes. Which
is fantastic. Oh, Mirat, we lost you at the most crucial bit.
Don't worry. Yeah, so I was saying that, yeah, I think we will hopefully slowly shift people towards that as we work more with communities, bring that agenda into play. And we do have NIHR schools of public health research whose work is very much trying to do that at varying levels, but trying to do that as well. So there is work going on. And I think the call that you're talking about is echoed by people living with the condition. So it's very much about what we're trying to do as a centre is very much work with these communities and bring them in to shape things. But it is a slow process, I'm not going to lie.
Thank you, Mirat. Thank you for your honesty. May I get Bella, Ehinor and Circle to unmute and put their cameras on, if that's okay? So I think you've all presented us with so many things to think about. And so I'd like to just start off with a sort of wish list. If we had unlimited resources and time, what would be on your wish list for where we go to next? What do we do as a public health community, as a research community, and just as citizens of our communities that we live in? Bella, could I start with you?
Oh, I don't think I should start. I think I should hand over to Circle and Ehinor. They're here.
Okay, Circle.
I got a long shopping list for you. I think one wishes list, I just heard about the emphasis about medical model. I think in the public health research, if it will come away, not only just medical model, to addition for the community engagement model or community inclusive model, because a lot, I say before, a lot data, I know it's clinical, medical science, a lot data, but to make a balance from the data side, you can build with community engagement, that our practice, our experience, live the experience. Not only we've got a lot more data, we also got a lot of data evidence reflect to the local community. I mean, that's one wish list I would like to see. The other is if they will have even the research now you're here, all the research they were taking apart any research in the future in your life, do you think about a lot real life story? Even you don't know anything at all, it's okay to ask the community. I mean, their doors open to welcome you to be partner, to be as a partner, to be collaboration. Because what happened for our community, we asked so many researchers ask us for helping for focus group, helping this. We've been asking for many years, and I would like to say the one step forward. We are not just part of the partner or contribute in the focus group. We are part of the collaborator as a co-applicant in your research process. So that means we're building on much more real experience together in life together. Okay, and let me finish my third list. My other third list is because we are the community based worker, and we are not academic. Okay, put it that way. We do engage a lot of academic research, but it's good to build the capacity from your academic side, and then like cross-cultural learning, skill exchange. That will be good. We want to do something innovative, yeah, and we can do co-produce whatever proposal is it cross-cultural learning, yeah, cross-cultural skill. That would be good, yeah. That's enough for now. I know we got a lot shopping list, yeah.
Thank you, Circle.
You've done all the shopping list. For me, like Circle have said, we honestly need to change the way that we work to make it so inclusive. I would say my very first shopping list would be find out from community leaders the way to go forward. Find out what language would they use, because even if you have a model or you have a toolkit that people don't understand, is still of no use to the community that you're trying to reach. I had a meeting with one of the commissioners yesterday, and she was sharing with me the challenges that they had in translating the public health message during the pandemic. I remember I was part of that process where they wanted me to translate in Pidgin English. When I looked at the message, I said, if I have to translate it the way it is written, the message will still not go out the way it should. But then they said, oh, you cannot change the public health message. It has to go out that way. Of course I did it. But yesterday I was shocked when she was saying, you know what? Now we can now change the message to suit the community. So those are the things we need to start thinking of. How do we reach out to the people we want to connect with? In language, for example, I know researchers are fond of using emails. If I wasn't doing community work, I think I would be using emails. It's not part of my culture to use emails. I only do that now because it's compulsory that I check emails. So, but if I go on social media, for example, you have more audience. So I think they should just be a bit flexible as to how they, put their structure. But most importantly, because they're going to be talking to the community, they need to always find out what the community wants and how they can really engage. Yeah, I think that's my understanding. Career for me is just a big deal, because I can personally even understand most of those research works, even as an educated person. So imagine someone who doesn't even understand English. How do you expect them to cope? How do you expect them to to understand. So definitely they're not going to get involved. So for me, language barrier will always be my top list. Yes.
And I think those are wonderful provocations, both from Ehinor and from Circle. And just to add my own personal perspective, I mean, I think we've, as a research community, as kind of working together with community leaders and working also with very, very many patients and people with different lived experiences, I think we've done a huge amount over the past few years. I think, there is, there is a lot more kind of involvement and engagement with research. I think where we're at now is we need to move from the instrumental to the real partnership. And I think both Circle and Ehinor have kind of underlined that.
I think you've hit the nail on the head, all three of you. Mirat, I'm mindful we should get your shopping list.
I think they've been said fabulously, and I just think from my own experience of working with communities, it's really about finding those projects, those specific things that you can work on, and through that building your relationship of how you work together, because that then leads to a strong relationship that will carry on. But also it really helps us that work within the system and work within research understand the value of communities and the solutions that they create, and the fact that actually we don't need the solutions, and we often don't even need the questions. We often just need to start the dialogue, and everything's there. And so I think it really is about just trying to find ways of working together, but meaningfully.
Yeah, thank you. That's really insightful, and couldn't agree more. Fiona, I don't know if you can unmute yourself. Is that possible? Hi,
Yes.
Fiona.
Hi.
Are you okay asking your question?
Yeah, I think it wasn't so much a question. Just I think because we have found that we have been asked in the past about translating documents quite often after a study's already started into different languages. And I know that some disease areas, because I work in lupus research, and it does affect particular ethnic groups, various ethnic groups. And that's, but obviously we're stuck to what the grant funding is, and that does cause issues that we're then being able to fund translating patient information sheets and so on into different languages. And I mean, that can be we're just looking at recruiting from a hospital in Cardiff, and possibility of translating into Welsh, for example, which might be a requirement. I'm not too sure, don't quote me on that, but that's the kind of thing that we have found, and something I think was to bear in mind, maybe people applying for grant funding, think in advance whether or not it might be beneficial to do that, so you can reach people.
And if I can come in with a plug for the course, what is in the course is well, one of the elements of it is an overview of the research cycle and how you can integrate different activities at different stages of the research cycle, so that you can try and find the funding or put it up front in a grant application. And because sometimes, as you say, you kind of you might not think about things immediately, and so what we hope that the course will achieve is just building in that kind of, well, what do I need here, what do I need at this stage, what do I need at that stage, to become more inclusive.
And I think as well, including people at the grant application stage who you might not think of normally, like research nurses, who are the ones meeting patients on a day-to-day basis. They're not normally involved at that early stage, but I think, and obviously, yes, there's the patient groups as well we want to involve, but it's just going right back to the very start. Quite often people, not everybody who might be relevant is included at the beginning.
Thanks, Fiona. I too did some research in Cardiff, and I think it's in the legislation that everything has to be translated into Welsh. And wouldn't it be great if we could have something similar here? the closed caption are making me laugh, so I'm trying not to read it because my accent is obviously confusing it completely. I think another set of posts from Professor Bannock really focuses on this sort of holistic angle that we should be focusing on. And if I started with Mirat this time, the ability to think through a life course approach, that whole inclusivity that we've been talking about today. And obviously we've got our sustainable development goals that are part of what we're meant to be doing nationally and internationally. I just wondered if there were any thoughts that you had, Mirat, on how we have that whole picture building into some of our NIHR schemes.
So I think there are examples like our global health calls and some of the public health calls as well. So it's not, I'm not saying it's perfect, I'm just trying to start on a positive. But yes, so I hear where you're coming from. I do think this is a challenge for big organisations where the setup has been clinical and where significant amounts of our resources are still distributed clinically versus other aspects of the geographies and other aspects of the research spectrum. But I do think, and I'm not being, I don't think I'm being naive. I do think these calls that we've got, while they're not directly relevant necessarily to what we specifically do, but the global health calls and all those naturally are providing different ways of working, and actually they're already providing the need for different solutions in contexts where things are a bit more stark, you know, where it's a bit more apparent. And I think they're naturally building the case for how we then revamp and rethink of our domestic funding calls. And I don't think that's just us as a funder. I think that I can see that happening with other funders, the Wellcome and other funders as well, where actually what we seem to be trying to do is we're on this shift to widen what we're looking at a bit more. So I do think that's coming, but I think we have to keep pushing back up as well. So, you know, where you've got good examples, push it back up into the system, push it back up into the NIHR, ensure that you disseminate your research internally as well. You know, you share it with us again, even though I realise it's funded and I realise someone somewhere in the organisation will have a knowledge of it, but try and share it a bit widely, because I think that helps us build the case for it. Those of us who really believe in the approach, it helps us find the evidence of actually, look, this is what we need to do. This is the direction we need to take.
Thank you, Mirat. That's really helpful. And Bella, I know you've worked not just your fab work here, but also internationally. Are there any reflections on what Professor Bannock's been posting, that sort of One Health and inclusive research type approach from your side?
So it's a really great provocation. I spent a few years, you know, kind of working in low to middle income country settings, and the revelation for me, as someone who, you know, was born in Britain and, you know, has been part of research infrastructure in Britain, was just how much global health research cannot happen without community engagement. It is it's a deal breaker. And I suppose I try and carry that with me in, you know, where we are now. And I think we've got a lot to learn actually from some of the approaches from the Global South in thinking about how we do community engagements here. And because I think there is very much more of that kind of whole system and holistic thinking.
Yeah, and with the environment and the whole ecosystem, it's so important. It's almost like we lost sight of it, but it's just so fundamental. And I think I'd agree with you wholeheartedly. The other thing we wholeheartedly agree on is research wastage. I wondered if we could just explore that a little bit, because I think it's something that Chris Ritchie's spoken about, and it's something that we've been trying to address within our bit of the BRC as well. So the things that are being produced might be so great in terms of being a robust methodology in terms of a randomized controlled trial study, but because it's so exclusive, you actually can't apply the findings across our communities. And I know in public health, it's one of the key things that we always advocate on, is that ability for making research, especially clinical research, more inclusive, so that you don't have that wastage, because we do have very diverse communities that we will be looking after. And Bella, can I start with you, because I know it's something you're passionate about.
So thanks. I don't want to monopolise the airwaves, but absolutely. So there have been estimates, and I'm sure people on this seminar are very familiar with them. But there have been estimates that up to 85% of research is wasted. Either it's not designed properly, it's not inclusive, it's not applicable to people that it might benefit. I've recently been doing some work around clinical prediction models and artificial intelligence, and not that I want to rubbish all of that kind of work, I certainly don't, but there are examples that, because research participation or the inclusion of data to make the algorithm hasn't been inclusive, then it's only applicable to certain populations, and that is not going to make health equity happen any sooner. So there are, and that is not an example of research waste, but perhaps an example of how research could be even better. So I think, and again, I've just plugged the course in that there are examples within the course where you can find out about how people think that research waste might be minimized. And again, I would go back to saying that if you think about the research cycle and the different areas in which you can be more inclusive, then hopefully that might address some of these pretty shocking statistics about research waste.
Thanks, Bella. Ehinor, any thoughts from you on? It doesn't just have to be on research wastage. Any sort of closing remarks?
First of all, I want to say thank you for putting it together. Even though I'm really, really unwell because my body doesn't go well with the sun. It's been a wonderful session, really. And I hope that as we go along, we'll get to do better things. But so far, so good. Well done.
Well, Ehinor, can we pass on our thanks, and also from all of us, all best wishes to getting better. But thank you, Ehinor, it's been fantastic. Circle, any closing thoughts from you?
I think my closing thought is we do have opportunity to share our story, our challenge during the COVID. I mean, this is a very good opportunity. I've been talking about this story many times in many ways, but this for this platform, and that is opportunity for us to raise awareness to your side. Please do take the story seriously and reflect on your learning, because this is real life story. It's when we come across to share, we have a lot challenge ourselves. I say, when I'm talking about first I left the meeting, I was in tears, my eyes. I say, why we not get it? So that's the way we are sharing that. Hopefully, we contribute something to the research, the learning and reflection.
Oh, that's just so fantastic. And I'm going to actually close the session on that marvellous note and take the opportunity to thank all of our speakers today. I've learned so much from you and continue to learn from you. So please don't stop speaking to power. I think everything that you say has got so much that we all should be saying. We've obviously got all the resources that are in the chat, and we will be producing a daily digest as well as the recording. And I know that Bella has put in ways of contacting us, and Mirat kindly gave us her contact details. So I hope this is just the beginning. And I think Chris has said there's so much for all of us to do. We hope you'll enjoy the teaching resource, and yeah, I'd like to add my personal thanks to Kath, who just does a fantastic job with everything that she does with us, and end on a happy note that even though the journey is ahead of us and it's not going to be easy, I think we've done such amazing work, and you've all been so great in sharing that with us. And I'd just like to thank you for having this session and being part of our Public Health Festival. Thank you so much, and thank you to the delegates. Take care, everyone, and please have a look at the programme for the other sessions for the festival. Thank you.
And thank you, Aparna.